George Sadek and Dr. Rahul Mahajan are presenting work on TCD pulsatility index correlations with EVD weaning outcomes. Thank you so much for joining us.
Of course. Good morning, everyone. Let me pull up my slides. Okay. Can everyone see my screen?
Yes, perfect.
Great. Thank you. Good morning, everyone. So my name is Dr. Sadek. I'm one of the second-year neurocritical care fellows at Mass General Brigham, joined with Dr. Mahajan as well, who's been my project investigator on this project. And we'll be talking about TCD metrics specifically with EVD weaning outcomes. We have no disclosures. So what are the things we know? We know that we need EVDs to control ICPs and manage hydrocephalus in a lot of different neurological emergencies, such as aneurysmal subarachnoid hemorrhage. And we know that EVD weaning could be challenging, and sometimes clamp failure, whether due to clinical symptoms, radiographic changes, ICP changes, could all eventually sometimes lead to permanent CSF diversion via techniques such as VP shunting. We also know that clamp failure sometimes could happen up to 24 to 48 hours after the initial clamp trial, and sometimes that would also lead to prolonged ICU stays. We have a great tool, which is TCD ultrasonography, which is non-invasive and can also give us some metrics such as cerebral blood flow velocity, and gives us one specific index, which we've been looking at a lot, which is a pulsatility index, which typically reflects downstream cerebrovascular resistance and intracranial compliance. And nicely enough, we often have this routine data in a lot of TCD studies that we do in patients who have EVDs and have aneurysmal subarachnoid hemorrhages. Just a reminder for everyone, this is the typical formula for pulsatility index, which is peak systolic velocity minus end systolic velocity over mean flow velocity. So I'm just going to jump to some observations that we noticed looking at some of this patient data. So I'm going to start with the first case, which was a 74-year-old woman who was admitted with a subarachnoid hemorrhage. It was Hunt-Hess 1 modified Fisher 3. It was a giant right MCA bifurcation aneurysm that was clipped. And post-clipping was getting the routine pulsatility index and daily TCDs. On post-bleed day 10, around 8:50 a.m., we have all this data here. So this is across different depths, across different vessels, and this is our pulsatility index. The EVD was clamped the following day at around 9:56 a.m. We happen to have TCD studies done at 10:20 a.m. And you could almost see that across the board, across all of these different vessels, there was a decent increase in the pulsatility index across all of them. And just looking at the waveforms as well, pre-clamp, we could see here this was the right MCA at a specific depth of 59 millimeters. And the pulsatility index at that point was 1.06. Meanwhile, during the actual clamp trial, we could see that the pulsatility index and the waveforms as well have gotten a little higher now at 1.37. Clinically, this patient had normal ICPs during this clamp trial. However, a CT had the following morning showed that there was worse hydrocephalus, and the decision was made to reopen the EVD at that point. Eventually, down the road, 10 days later, the patient did require a VP shunt. Similarly, we have another case of a 66-year-old lady who had a little worse subarachnoid of Hunt-Hess 3 modified Fisher 4 from an ACOM aneurysm that was then coiled. Similarly, we have here pulsatility index data on post-bleed day 17. On post-bleed day 18, the EVD ended up getting clogged, didn't have any output. The waveform was still fine. And we could see, at least in some of these vessels, that the pulsatility index also did go up. We have similar waveforms that show us that, again, with the right MCA, pulsatility index went from 1 to about 1.56, and we can see that same effect on the waveform. Clinically, pretty similar. The ICPs were normal during this time. Neurosurgery ended up flushing the EVD. The waveform normalized the following day. And subsequently, the patient still unfortunately needed a VP shunt 11 days later. Which leads us to, look back and say, is this something that, what do we know, what do we not know about pulsatility indices in these specific situations? So what we do know is that the pulsatility index does correlate with ICPs, intracranial pressures, and cerebral perfusion pressures. We also know that a high pulsatility index is a marker of distal resistance and port compliance. What we don't know is most of this literature focuses specifically on a static pulsatility index, like a snapshot in time. And really few studies utilize this clamp trial as almost what we're calling a stress test or a provocative maneuver to check for cerebral compliance. Sometimes we just focus on frankly abnormal ICPs, but we've seen that this could still happen with normal ICPs. And as far as we know, there's no direct evidence linking a pulsatility index change during a clamp trial and to see whether this leads to successful weaning across this diverse patient group. So our main question based on all this is, can we predict EVD weaning failure physiologically before any clinical decline occurs? And the main two things we focused on is, could these PI changes during a clamp trial predict whether that specific clamp trial is successful or not, but also eventually would a patient need a VP shunt or not? I'm just going to briefly talk about what we did so far. So we had a retrospective single center cohort just at Brigham and Women's over 5 years, where we filtered patients who had EVDs placed for multiple reasons, whether it was subarachnoid hemorrhage, interparenchymal hemorrhages, with or without IVHs, or TBI who had TCD data. And we excluded patients, obviously didn't have any TCD studies specifically during a clamp trial, or if there were more than 3 days apart from the specific clamp trial. Some patients never had the EVD clamp for clinical reasons or had bilateral EVDs in place, so we thought that that could confound some of our data. Or some patients had clotted EVDs, which weren't in that time frame as well, or the EVDs never worked thereafter. Or some patients had lumbar drains placed, so we thought all these could be confounding variables, so we excluded these specific patients. So prelim results so far, we were able to screen 451 patients who just had TCDs done, out of which 170 had EVDs placed during that time. Based on the exclusion criteria I mentioned in that past slide, 86 were excluded. We ended up with 84 patients. Some of them had multiple clamp trials during the same hospitalization. So we utilized some of these patients who had multiple clamp trials to see if these outcomes, whether EVD, weaning, or VP shunt, were also included. Our typical baseline demographics here, so average age of median of 58, 61% were females, a median of high-test 3 and modified Fisher 4. So, the most notable difference we saw was with the VP shunt requirement. So over here in blue are patients who did not end up needing a VP shunt. What we ended up doing is we actually measured the average across all vessels for the PIs, and to see or assess the difference, we tried to see if the ratio of during a clamp trial or post-clamp over pre-clamp was showing any difference. So you can see here that, yes, we do have quite a variation of outcomes, but overall, the mean PI ratio for patients who did not need a shunt was 1.009, and that was 74 of our patients, versus a little higher here of 1.046, with a p-value of 0.15. So it did not reach significance, but there was some signal there that is worth exploring further. Similarly, but a little less strongly associated, was EVD weaning failure, where the patients who did not end up failing their clamp trials, PIs on average were 1.014 versus 1.029, but the p-value was not significant there. These definitely do have limitations. So for example, looking at our second case that we talked about, this was a pooled group level statistic. We checked all vessels at all different depths, and there could be some heterogeneity here that could mask any meaningful results. Similarly, we feel because of that, that it might be worth seeing would each looking at each vessel separately or the different so let's say, for example, if we just focus on the highest pulsatility index per vessel, or perhaps the vessel that had the highest mean flow velocity, whether that would specifically give us more information. Of course, it was a single study, so there could be some selection or documentation bias here, generalizability. I would like to have a bigger sample size, so that would be our next step, especially with power. Um, and as I had mentioned, some patients ended up having more than one clamp trial, and those were treated as separate independent observations. So although that sensitivity analyses did show some consistent null results, there could still be some form of correlation. Um, and there was definitely a time variability. This is a retrospective study, so it wasn't that we were specifically looking at someone's TCDs as soon as the clamp happened. So there sometimes were gaps of 3 days between a clamp trial and having some of these TCD studies. So there could be some physiologic changes there that we didn't capture immediately after a clamp trial. And at the end of the day, there are a lot of confounders still. So it's not a direct linear relationship, but there could be something such as the arterial CO2 levels or blood pressure or cerebrovascular compliance or even heart rate that could independently affect our pulsatility index aside from the ICPs. So what we're doing next is we're, as I mentioned, looking through different vessels, exploring different metrics, seeing if we just look, for example, based on where someone's initial aneurysm is, or if that side or the side where their EVD is placed could specifically affect whether we should be looking unilaterally versus bilaterally at some of these vessels or anterior versus posterior circulation. We're including more patients. We could look into sites like Mass General as well and try to pull some of that data or see if there is a similar correlation. Across time and also try to incorporate some of the values that we would have documented, such as blood pressure or intracerebral pressures during those trials. And then we could also use some nonlinear machine learning of some of these metrics or waveforms to help us dictate future studies. So the main things that we're able to at least glean from this is that the PI changes could happen during a clamp trial, even if the ICP remained within a normal range. However, it looks like the at-group level pooling across all these vessels wouldn't necessarily differentiate failure versus success at this point. There was a modest non-significant trend with the VP shunting, but I think definitely needs more time and more data to help us see how significant that trend is. But clinically, definitely pulsatility indices remain a useful tool for tracking these resistance and ruling out high ACPs, and it does have a good negative predictive value. And we're still working on this, so that is it. I'm opening the floor for questions.